Welcome to this educational program. This module discusses a surgical treatment for testicular cancer called radical orchiectomy. A separate presentation entitled Understanding Testicular Cancer is also available, and it is hoped that you will have viewed this already. The information in this presentation is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider or the specifics of your situation. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or to skip through them in any order you wish. A radical orchiectomy, which is also called inguinal orchiectomy, is a surgical procedure that's performed when testicular cancer is suspected. In almost all cases, just one testicle is involved. However, in less than 5% of cases, men may develop testicular cancer in both testicles. The purpose of this type of surgery is to remove the testicle as well as the spermatic duct so that the mass or tumor in the testicle can be examined to see if cells in it are cancerous. Cancer cells are found in more than 95% of testicular masses. When testicular cancer is suspected, the entire testicle, along with the spermatic cord, are removed, and this is done through a small cut or incision in the groin, and not through the scrotum. The incision is very similar to those performed for classical hernia repairs. The term radical simply means that not just the testicle, but the surrounding structures are removed. It is an ominous-sounding word, but in reality, this is a fairly simple and small operation, and performed as an outpatient procedure, meaning you will be able to go home after the procedure is performed. It is curious that an operation on the testicle should be performed through a cut in the groin area. There are several good reasons for this. Firstly, the blood and lymph vessels of the testicle, where cancer might spread through, both come down through the abdomen, through the groin, and into the scrotum. And the testicle, in a sense, hangs into the scrotum on this cord of structures. The reason testicular cancer spreads to the abdomen has to do with the fact that the testicles are formed in the region of the kidneys and then descend down into the scrotum just prior to birth in male children. Approaching the testicle along the spermatic cord therefore provides better cancer control because one can isolate these blood and lymph vessels further away from the testicle. It also helps to avoid having to cut into the skin of the scrotum, which might contaminate the skin with cancer cells, or alter the drainage system for the lymph channels. And all of this might change how the cancer has to be treated afterwards. The lymphatic drainage of the scrotal skin is to the groin region and not the upper abdomen, and therefore an incision in the scrotal skin could change the drainage of cancer cells from that in the upper abdomen to the groin region. This drawing shows how the blood supply to and from the testicle travels in the so-called spermatic cord along with the sperm duct, or vas deferens, through the groin and into the abdomen to the great vessels of the body, the area where the kidneys are found. In many cases of cancer, a biopsy can be done without removing the suspected organ. One example is breast cancer. However, with testicular cancer, there are two good reasons to avoid a biopsy before surgery. Firstly, 95% of testicular tumors are cancerous, so doing a biopsy is not usually necessary. It only confirms the obvious and delays proper treatment. Furthermore, living with one testicle does not have an impact on a man's sexual life or ability to father children, so there is minimal physical impact of proceeding with removal of the testicle. Secondly, as mentioned, doing a biopsy with the testicle intact requires cutting across the scrotum, and this is known to increase the risk that cancer cells from the tumor will spread from the testicle, and this spread may occur in a more widespread fashion than might occur otherwise. There are rare occasions when a biopsy might be performed. For instance, when there is an uncertain appearing mass in a solitary testicle, or masses in both testicles, where complete removal would leave the patient without testicles and male sex hormone production. In these cases, the biopsy is performed through the incision in the groin after the testicle is brought up from the scrotum and not through the scrotal skin. Prior to coming to surgery, you will meet with your urologist, who is a surgeon specializing in the genitourinary tracts. A medical interview will be carried out, and your medications and allergies will be reviewed. A physical examination, including testicular exam, is then performed. These findings are then reviewed, and treatment options, including surgery, are discussed. Testing is ordered to further assess the suspected testicular cancer. This testing may include blood tests and imaging such as X-rays and CT scan. The purpose of all of this is to properly stage the disease, meaning to determine the extent of the cancer to find out if the cancer has spread elsewhere in the body. This is important in determining the best treatment. If you have any concerns, they should be reviewed at this time. Be sure your doctor is aware of all your pertinent medical information, especially the medications you are taking, including over-the-counter medications and supplements, etc. Some medications and supplements can increase the risk of bleeding during surgery and must be stopped beforehand. Ask about your medications, including what you should continue taking up to the time of surgery. Following this review, you will be asked to sign informed consent for surgery. This is a very important document which indicates that you understand why your surgery must be performed, other treatment options, what surgery entails, and what the potential risks are. The consent also allows your doctor to perform any other procedures that are deemed necessary to save your life, and to use the assistance of other medical personnel, such as other doctors, nurses, and students. The consent also normally includes a note that allows your doctors to use blood or blood products if deemed necessary to save your life. If you have an objection to this, you must notify your doctor and have this section adjusted accordingly. Finally, some centers may ask for consent to use and study tissues collected at the time of surgery for research purposes. Once this is done, it is time to prepare for surgery. In the time leading up to the operation, focus on living as healthy as you can, eating a balanced diet, and getting some exercise. Gathering the support of friends and family around you, as well as other patients who have been through this when possible, can help ease your mind and comfort you. Try to take other measures to reduce stress as well. Arrange time off work well ahead of time, and organize some help with household and other tasks before and after surgery. Learning about your condition and your surgery through programs like this can also help to relieve anxiety by removing the mystery of what is happening to you. Finally, it is important to understand and come to terms with the expectations of surgery as well as the potential outcomes. Radical orchiectomy should be done as soon as possible because testicular cancer can be fast-growing. Many urologists will try to perform these surgeries within a few days of confirming a testicular mass. Staging tests should also be done quickly, but should not delay surgery, as they can be done soon after surgery. Some kinds of cancer produce what are called serum tumor markers, which show up when a blood test is taken. This means that the levels of certain proteins or enzymes in the bloodstream are higher than normal. In the case of testicular cancer, there are 3 such markers: alpha-fetoprotein, or AFP, beta-human chorionic gonadotropin, or beta-HCG, and lactate dehydrogenase, or LDH. If you have a testicular tumor, a blood test taken before surgery may show elevated levels of one or more of these markers. These markers also aid in making the diagnosis of testicular cancer and in making treatment decisions after surgery. These markers can also be used to determine if treatment is working. For example, if a testicle is removed and the level of one of these markers decreases back to normal, your physician will know that it's unlikely that the cancer cells have spread beyond the original tumor. To complete staging of the cancer, a chest X-ray and abdominal CT scan will also be performed. The purpose of these is to determine if cancer cells have spread into the lymph nodes or other organs in the abdomen. Depending on the results, your urologist will be able to make some preliminary decisions about additional surgical procedures that may need to be done after the removal of the testicle, or other treatments such as radiation therapy or chemotherapy. For almost all men, removing one testicle will have no significant impact on his fertility, in other words, his ability to father children, or his sex life. While the cancer itself, as well as other treatments such as chemotherapy or radiotherapy, can cause infertility, the actual removal of the affected testicle has very little impact. The remaining testicle will not only continue to produce sperm, but it will also produce adequate amounts of the male hormone testosterone, so normal development of secondary sexual characteristics such as facial and body hair, deep voice, etc. are preserved, and sex drive and erections will also be maintained. Removal of one testicle also does not cause any other health problems, and it will not be noticeable to most people. Many men, especially young men, are concerned about how they might appear after removal of one testicle. As mentioned, most people will not notice the absence of one testicle, the exception of course being one's partner. Having said this, having only one testicle can have a psychological impact on a young man, and may cause him to feel embarrassed, self-conscious, or even depressed. When necessary, an implant or prosthesis, which is a substitute for a natural body part, can be placed into the scrotum to fill the space left behind by the removed testicle. Implants can be placed at the time of testicular removal, or they can be placed afterwards at any time. Multiple sizes and types are available, including saline-filled ones, silicone gel implants, and so-called soft-solid implants. The decision as to whether to have an implant or not is a personal choice. Keep in mind that these implants are not in any way functional, and placement of one is strictly for cosmetic purposes. The major benefit is to lessen the psychological impact of removing a testicle for some, to improve his sense of self, etc. The disadvantages of testicular implants include the fact that they require some additional surgery and carry some additional potential risks like infection and an additional expense. Another question that many men have prior to orchiectomy is whether or not to bank sperm. Because testicular cancer and some of its treatment can impair one's ability to father children, banking sperm is a good idea if you have plans to have children in the future. However, removing one testicle will not affect fertility significantly, so sperm banking can safely be done later and should not be a reason to delay surgery. Sperm banking can be discussed in more detail with your doctor after the operation. Special consideration to this should be given if you are to receive any chemotherapy or radiation treatments after orchiectomy, or if further surgery for testicular cancer is to be performed. While awaiting surgery, please understand that testicular cancer is not in any way contagious or hazardous to your partner, so there is no need to worry that you may be putting her at risk. The next several slides will discuss the procedure of radical orchiectomy. The night before the operation, eat a light meal, then take nothing by mouth for several hours before surgery. A common instruction is to take nothing by mouth after midnight on the night before the operation. However, individual instructions will vary. Try to get a good night's sleep, as it helps to go into surgery well rested. Finally, as individual situations will differ, follow the advice of your doctor or hospital regarding specific preoperative instructions. On the day of surgery, have someone drive you to the hospital and try to arrive early. You will likely first go to the admitting department and have some paperwork done to check you into the hospital. You will then be checked into the surgical area, where you will change into a hospital gown and meet with a nurse. The nurse will review your medical history and check your vital signs, including your blood pressure, pulse, and temperature. An intravenous or IV line will likely be started, through which you will receive fluids and later medications. At some point during this process, you will meet with an anesthesiologist, who will administer anesthetic drugs and monitor your vital functions during surgery. The anesthesiologist will review different anesthetic options with you and discuss their merits and potential risks. Finally, prior to surgery, you will meet once more with your surgeon, and any final concerns can be addressed. A general anesthetic is used for this procedure, which takes between 30 minutes and 1 hour. An incision, about 2 inches long, or 5 centimeters, is made in the lower abdomen. Most often, radical orchiectomy is done on an outpatient basis, but sometimes physicians prefer that their patients remain in hospital overnight. Once in the operating room, an intravenous line will be started if not done already. Typically, you will then be put to sleep by the anesthesiologist, and a breathing tube will be introduced. The doctors and nurses will then carefully position you on the operating table in such a way as to optimize the ability of the surgeon to carry out the operation. For a radical orchiectomy, you will typically be placed flat on your back. Once positioned, the skin is cleaned with special antibacterial solution, and a short incision or cut is made in the groin. Through this incision, the surgeon will push on the scrotum to deliver the testicle into the incision, which allows the isolation of a cord of structures called the spermatic cord, which contain the blood vessels to and from the testicle, and the sperm duct called the vas deferens, which transmits sperm from the testicle for ejaculation. The testicle essentially hangs on the end of this cord and can therefore be pushed up and brought out through the incision as shown in this drawing. Next, the surgeon will clamp and tie off the structures of the spermatic cord as high in the groin as possible. The testicle is then sent to the lab for analysis by a pathologist. The incision is then closed using strong dissolvable sutures on the inside and staples or dissolvable stitches in the skin. A dressing is applied to cover the incision. Once stable, you will be transferred to the recovery area and/or day surgery area for further monitoring. You will be observed for at least an hour, then discharged home with your ride once you are deemed to be alert and able to travel. It is unusual for an orchiectomy to cause pain for more than a few days, but pain medication is prescribed by most physicians. Commonly, there is some numbness around the incision, which gradually subsides. The area may remain sensitive for a couple weeks. Wearing loose clothing will help. A small amount of bloody discharge is normal as the incision heals. Some mild swelling and bruising is also normal after surgery, and an ice pack can be used to help reduce this swelling. You'll be advised to avoid most activity for a few days, particularly lifting. It's difficult to predict how long you can expect to be off work. Some men feel well enough to return to their jobs after a few days, and this is okay as long as you are doing only desk work or light activity. Others require a week or more. Your doctor will also likely advise you to avoid lifting more than 10 pounds for at least 1 week after surgery, and gradually increasing your level of activity and exertion. Be patient and try not to push your recovery time if you are not feeling well enough. Risks of radical orchiectomy are uncommon and usually minor, and may include excessive bleeding, which may rarely require another operation to drain blood and stop the bleeding, wound infection or other wound problems, such as delayed wound healing or a collection of fluid under the wound, and bowel injury, which is extremely rare and caused by not recognizing a piece of bowel that has herniated along the spermatic cord. The risks of modern anesthesia are generally rare, but depend on the health of an individual and will be discussed in greater detail by the anesthesiologist. Undergoing placement of a testicular prosthesis at the time of orchiectomy does very slightly increase the chance of experiencing a complication. As with any foreign material, testicular implants can become infected, requiring their removal, and they can erode or extrude through the skin. Occasionally, implants may need to be removed due to malposition or migration out of position, or due to pain or discomfort related to the implant. This may be required in up to 1 in 30 cases. Many modern implants contain silicone gel, and there is concern that this gel can escape out of the implant and cause an immune reaction whereby the body attacks its own tissue, causing inflammation and scarring in otherwise healthy tissue, even in other parts of the body. This so-called autoimmune reaction, or human adjuvant disease, has been observed in patients with breast implants and is the source of controversy around these, but it has never been described in relation to testicular implants. Finally, as a natural reaction to any device placed in the body, scar tissue may form around a testicular implant and create a capsule. Occasionally, this capsule can contract, causing a condition known as fibrous capsular contracture, which can lead to hardening of the implant with subsequent discomfort or pain. Follow-up visits will depend on your situation and the preference of your surgeon. Early after surgery, as soon as the pathology becomes available, your doctor will check the healing of your incision and will discuss the pathology report with you. This is the report issued by the doctor in the lab, a pathologist, who inspects the specimen and examines it under a microscope. At least 4 weeks after surgery, blood tests will be repeated to re-measure tumor markers if they were elevated prior to surgery. If necessary, further treatment will be organized, and plans will be made for regular follow-up visits. It can take anywhere from a few days to a couple weeks to get your final pathology report back. Several important questions about your tumor, which will impact on your prognosis or outcome, and your treatment plan, will be answered by this report, including: Is testicular cancer the correct and final diagnosis? What type of testicular cancer is it? How big is the tumor? What cell types are present in the tumor? Does the tumor invade the lymph channels or blood vessels? And is the tumor growing beyond the borders of the testicle? Most testicular cancer patients with localized disease, in other words without spread outside of the testicle, undergo a regimen of regular follow-up examinations after surgery for at least 5 and up to 10 or more years, including periodic assessment by a physician, measurement of tumor markers, and imaging with chest X-ray and CT scan. The exact schedule of follow-up visits will depend on your specific clinical situation, as well as the preference of your doctor. This slide outlines a typical follow-up schedule. Your situation and the preference of your doctors may vary from this. The first year, diagnostic tests are performed every 2 to 3 months. During the second year, the frequency is reduced to every 3 to 6 months. After that, most patients are retested twice a year. Most relapses occur during the first year after treatment, which is why testing is so frequent. After 3 years have passed, testicular cancer reappears in only 5% of patients. After 5 years, the chances are even lower. In certain situations, further treatment may be needed following radical orchiectomy. The need for such treatment depends on several factors, including the type of cancer, the extent or stage of the cancer, certain indicators of aggressiveness, such as the type of cells in the specimen and invasion into lymph or blood vessels, the response to initial treatment, and the pre- and postoperative tumor marker levels. Possible treatments may include surveillance only, meaning no further treatment but close monitoring with lab tests and imaging, chemotherapy, radiotherapy, or further surgery, such as an operation called a retroperitoneal lymph node dissection. Testicular cancer can be cured with modern therapy. In fact, the ability to cure testicular cancer is one of the most remarkable and encouraging stories in all of medicine, and is a tribute to the hard work and brilliance of many scientists and clinicians over the past several decades. When discussing the likelihood of cure, keep in mind that the word cure is difficult to define and may be different with different types of cancer. With testicular cancer, cure is usually defined as no evidence of recurrent disease after 5 years of follow-up. However, late reoccurrences can happen in rare cases. Informing a man of his chance of cure after radical orchiectomy is more challenging than one may think, as it depends on a number of different factors, again, including the extent or stage of cancer, the exact type of cancer, the response to treatment, and certain indicators such as the presence of tumor invading into blood vessels and pre- and postoperative tumor marker levels. Every man's situation is unique, and generalizations are difficult to make. Please discuss the specifics of your personal situation with your doctor. If there is going to be a recurrence of testicular cancer, it is likely that it will appear within the first year. After 3 years of being cancer-free, the likelihood of being cured is 95%. This is due to advances in medical science which have made testicular cancer highly curable even when there is a recurrence. Being vigilant to attend all scheduled follow-up visits is extremely important. In summary, radical orchiectomy involves the removal of a testicle with surrounding structures and part of the spermatic cord. It is performed when testicular cancer is suspected. The operation is done through a small incision in the groin in order to optimize cancer control. This is a minor outpatient procedure, and it is a safe procedure with minimal risks. It should be performed as soon as possible after the diagnosis of a testicular mass is made. The results of the microscopic examination of the specimen and the response to treatment, as indicated by a drop in the level of certain tumor markers, will determine the appropriate management of testicular cancer. Finally, be assured that the cure rates for testicular cancer are very high.